Hey, I'm Trey Tucker, mental health therapist, and this is Rugged, where we make your 20s and 30s legendary. If you've ever been curious about ketamine or other psychedelic therapies, today's your day because I got Dr. Vando on the show. He's a psychiatrist. He's an expert in ketamine and all the other various forms of psychedelics. He's also an advisor to Mindbloom, a company that specializes in this stuff. I think you're going to learn a lot today. It's going to be really helpful. Let's go.
Since the beginning, I've been telling people you have to exercise. And even I came up with ideas like, look, it's not just moving. You just have to get to sweating. And once you're sweating, just to kind of measure some intensity, you have to stay at that level for at least 10, 15, 20 minutes and then move up from there. And now there have been studies, more recent studies studying the connection between certain myokines and the brain, meaning molecules that are produced in your muscles when you exercise and how they affect or influence your brain activity. Which I'm not an expert in, but it just gives me some validation that what I've been doing it helps. It helps me.
Yeah, I mean, there's
Just to get, I'm just to give you some personal context. I come from a family where we're four brothers, and three of them have been on SSRIs for the past 20 years. I think I've largely managed to avoid them by my very specific exercise routine or consistent exercise routine.
Wow. And yeah, I mean, we know it anecdotally, and now you're saying there's actual research that shows.
Oh yeah,
Yeah,
without a doubt.
man.
In fact, for mild and moderate depression, exercise is probably more effective than any medication we know. Not ketamine though, but SSRIs, SNRIs, etc.
Yeah. All right. You mentioned ketamine. That's one of the things I'm most curious about. So I know you pioneered some protocols. So the average person, I think they've probably heard of ketamine, but that's it. So what can you tell the average person that doesn't know anything about it?
First of all, ketamine has been around for roughly 50 years as an anesthetic. So we have thousands and thousands of papers on how safe it is. Psychiatry discovered it probably in the past 25 years as an agent that had potential psychiatric implications. And since then, if I tell you several hundred papers have come out, including one of ours that we follow over 11,000 patients, 10,000 patients, proving how effective it is for depression and anxiety. What people should know about ketamine. So, how it works. In layman's terms, it's an NMDA receptor antagonist. Basically, what that means is that it attaches to a specific, you can call it like a volume knob of nerve cells where the glutamate receptors are, and it just kind of turns down the volume of that depending on the dosing. And that allows the pain signals and the stress signals to temporarily just go down, temporarily mute it. The temporal mutation causes a cascade of events. One of them is it allows it's like a quiet time. It allows the brain to trigger a surge of growth factors like brain-derived neurotropic factor. And I'm going to, use that as a trailhead to so brain-derived neurotropic factor, known as BDNF, is the common pathway for every activity that gets you undepressed, every activity that relieves anxiety or stress or PTSD. Whether it's exercise, whether it's whatever, an SSRI, ketamine treatment, etc. So that is the common pathway. What that molecule does is it allows plasticity in the brain, it allows the neurons to kind of sprout more connections, which is why many people feel their mood lift within hours. One of the reasons it creates that temporary state of somewhat numbness or dissociation allows people to revisit memories or experiences with almost detached, dreamlike state. And that visitation as an adult with less emotional attachment to it allows us to see, you know what, this cannot hurt me anymore. This cannot hurt me as much. And that allows healing. I want to, clarify two more things there. One of them is I like to be hyper aware, and this is what I teach the residents, this is what I teach the clinicians, that everything we've known about science has been proven to be wrong or incomplete. In the history of humanity, everything we know has been proven to be. So whatever I'm saying right now, there's a small chance that we're going to say, okay, he was missing something else. So, but what we do know now, what we do know from many clinical trials, including ours, is that it's powerful, it's safe, and it's very effective for depression. And in fact, the original ketamine studies, trials were done on people with treatment-resistant depression. These were these were people who had tried, depending on the definition, several antidepressants and had not responded. Um, and for even for them, it was very effective. The second thing I want to mention is that you mentioned I pioneer the protocols, but I don't want to take credit for that.
All right.
I think the patients pioneer the protocols. We just listen to the patients. So yeah, I don't want to take credit for that because it's really been feedback over thousands and hundreds of thousands of sessions that we listening to the patients and collecting feedback and collecting data, not personal data, clinical data, um, in which we try to understand how various things from absorption to kinetics to pH, things that will impact the ketamine experience, to what they've eaten, to what their day was like, to what their mindset was, to how much work they put in into the intention, into other areas, and to medications they're taking. So we're taking a whole bunch of information and put it together. So these protocols are not mine per se, are the collective experience of thousands of patients.
Yeah.
Same as medicine. I think medical schools should be free.
Interesting. Okay. I like that, Don.
Yeah, no, absolutely.
Tell me more.
Yeah, it's been thousands of years of human knowledge, and nobody should own it. Education should be free.
Yeah. Yeah. Okay. That could be a whole different conversation on a different podcast episode. I like where you're going there. I like the way you're explaining ketamine because it's easy to understand. Basically, if I'm hearing you right, you're saying that the protocols are based on the hundreds or thousands of people who you've collected data from in their trials. And then what ketamine is doing in the brain is it's basically making it more plastic or more changeable, and it allows you potentially
Right.
to go back to those memories that may have been causing pain and work through them without as much pain. Is that a fair summary?
Well, that's one aspect of it. The reshaping of memories and relearning. If you one way to explain, let's say, depression is the concept of learned helplessness or hopelessness. Waking up every day and feeling terrible, and no matter what you do, what you eat, how many vitamins you take, or what relationship you end or not, you still feel lousy. And at some point, you learn, your brain learns that this is the way to live. Sometimes what an effective antidepressant does is it allows the brain to learn that no, you can feel better. In fact, I had a session earlier today, and sadly, she told me, I wish I had not taken ketamine before because I had forgotten what having suicidal ideation was like. And then now I stopped taking ketamine for about 6 months, and now they came back. It wasn't a lot, but just the thought it. She said, "Oh my God, it's like they stole something from me now." So she learned to live a life without depression and anxiety and without suicidal ideation. That malleability of the brain is allowing it to say, I can feel better. But also that ketamine is a wonderful molecule because it does a couple of different things. Not only it makes your brain more malleable, but it gives you an almost immediate boost in your mood. So, and that's important because for people who wake up every day of their life for the past 15 years, waking up depressed, and all of a sudden you try a treatment, and the next day you feel better. You will say, "Oh my God, I don't have that hanging over me." That's a powerful shift in perspective and hope.
Yeah.
And again, bringing back the psychiatric experience. In traditional psychiatry, you decide, okay, I'm going to, and I understand you're a therapist, so you've probably seen this with some of your patients. Oh, okay, you've been working with a patient, and you say, please go see a psychiatrist. I mean, not that everybody should go see a psychiatrist, but I'm sure you've had patients who medication has been enough. And the first they call, the next appointment is 3 weeks from today, so that's a 3-week wait. And then they start medication one, somewhat effective. Then the psychiatrists have a couple of choices: raise the dose, change medication, or add another medication. That's another 2 or 3 weeks. So we're talking 2.5, 3 months before that person gets relief. So that's at a minimum 90. And this is a really best case scenario that they respond or partially respond to the first medication. The vast majority of people are not in that bucket.
Yeah.
So we're talking the best case scenario, somebody's going to feel better. Somebody's going to have at least an additional 90 days of suffering before they get relief. That's wild.
Yeah, that is wild. But it's crazy that we've accepted that as just, well, that's just the way it is.
Well, 1 in 4 adults in the US has had a major mental health illness in the past year. 1 in 4. That's a lot. In people under 40 or 45, I don't recall this the right number, suicides and overdoses are the leading cause of death. So, effective and fast mental health treatment is important, and it's part of our mission.
Yeah, it's critical. So what do people do to maintain the improvements they get after their first ketamine treatment?
There's a variety of things people can do. My view is that consistency beats optimization in almost everything. It's better, and this was my message to this lady this morning. Said, look, if you do ketamine and then you stop for 6 months and you wait until you get depressed again, that's just not a great strategy. You're teaching yourself that you're going to get depressed again. And so usually the strategy is find the pattern in which the cadence at which you prevent going back into a depressive state. Again, this is just the pharmacological aspect of it, but things that people can do to maximize the response for ketamine. Going back to the basics: exercise, the basics of health, exercise, good sleep. Sometimes you need to make decisions in your life that psychedelics kind of bring to your attention. So making those decisions, be more mindful about how you think and how you relate to things. But ultimately, the way people approach ketamine therapy is it's a proxy to how they approach other things in life. People that take it seriously and they approach it and they do their work diligently, or people who just do the minimum they can to just survive. So
basically, which
again,
yeah.
Well,
so you're saying ketamine doesn't do the work for you. You have to do the work. It just helps facilitate to make your work more effective.
Yeah, I mean, it's absolutely. It's like I don't think even in the world, just bringing it back to exercise, even in the world of athletics, there are, I've seen all throughout the years, I've seen all sorts of inventions come to the market so that people don't have to exercise, stimulators and things like that, supplements. But no, you still have to go and sweat. It's just the way it is. And look, it's hard to generalize. There are folks who have been in such a severe depressive state that they will not have the energy to do anything else. In these cases, ketamine is profoundly helpful and will give you that kickstart, that boost to just get going. And I've seen it happen hundreds, if not thousands of times. I'm going to zoom out and generalize from ketamine to psychedelics. There's some work that needs to be done that either you do it before you do psychedelics or you do it while you're doing psychedelics. And in a way, it's probably better to do it before you do psychedelics. Particularly if you have significant trauma, if you have memories that you can't even touch, experiences that you can't even hold. It might be a good idea to do some work with someone and have some, at least, transient secure attachment with somebody else so that you could work on this, so that you have a safe space, somebody to work with.
Yeah. Good. What are the differences in ketamine and other types of psychedelics? And do you think ketamine is the best in all cases or just in some?
I don't think there's I don't think there is a best of anything for everybody. I think there's not a best exercise for everybody else. I think people have to find how they move and see what works for them. I will tell you a few differences. Ketamine does not directly work through the serotonergic pathways. Uh, and that, in my opinion, is an advantage because most folks who have been in psychiatric treatment in the past 20 years, 30 years, have had their serotonergic pathways abused um, by the medical system.
Mm.
You know, at the first sign of distress, and I did it as a psychiatrist. You know, so at the first sign of distress, somebody, we just put them on an SSRI.
Mm.
You know, of the billions of neurons we only have a couple 100,000 serotonergic neurons. And again, at the first sign of distress, just to bombard them with an SSRI is just probably not a great idea.
Yeah.
And serotonin is involved in so many different, it touches so many aspects of our lives, of our perception, but it touches our connection with our connection with the external world.
Mm.
You know, from our gut microbiome to our senses. So it's probably not a good idea to just give somebody an SSRI at the you know, just because they're struggling with an experience. Um, so what I'm trying to say, just to connect that with the previous thought, is that most folks that come into ketamine treatment, or many folks that come into ketamine treatment, are already on an SSRI or a medication that affects serotonergic pathways.
Mm.
So ketamine is possibly a much safer, reliable experience. The the other issue is the predictability. Again, we know by now after hundreds of thousands of sessions how long the session is going to last. The way our protocols are set up, we start with a slow and incremental dosing, and we recruit what's called a peer treatment monitor. And all in all, we have about 7 hours of contact time with the patient by the time they're done with the first couple of sessions. So we have a pretty good environment set up for the patient. That and coaching, the guides, the support, the content that we created, content for depression, anxiety, burnout, loving yourself, you name it. Really amazing content. And the music. It's so, again, when most folks go to an office and they get IV ketamine for hundreds of dollars. They just go to an office and at most they'll get an eye mask or they'll get a TV with some trippy images. We invest a lot in music that helps improve the experience, and with guided music where you have a psychologist or a therapist just go over content that is specific to you. Yeah, and many other stuff that we have down the pipeline to improve the experience. But that's one of the few. Um, Another difference between classic psychedelics and ketamine is that this could be an hour and a half, 2 hours done at home.
You don't need anybody with you.
Sometimes, sometimes these classic psychedelics they last multiple hours, and sometimes even longer than that.
Yeah, interesting.
And hardly is that. Yeah.
Are there downsides to ketamine, or of course psychedelics too, but specifically ketamine?
I would say that the most important thing if somebody's considering ketamine treatment is look for a reliable provider. Somebody who's not going to prescribe it to you if you don't need it. Somebody who knows how to use it. Somebody who has a lot of experience with it, and somebody who also understands, who's a mental health clinician. Over the past, so when I came to Mindbloom, it was late 2019 as an advisor, and then early 2020 during COVID as the medical director. We had an office. By then, I had done thousands of intramuscular ketamine sessions, and this was in a very straightforward way. So a patient would come into my office, I would give them intramuscular ketamine, no setting, no psychedelic support. I didn't know better. But as I got more involved, one of the things that I noticed was that most of the ketamine prescribers are not mental health clinicians.
Yep.
And so, so I think that's some some of them are very experienced ketamine prescribers, and they do understand this psychological, the value of psychological support and preparation and integration, etc. Um, so I would say the downsides are falling into the hands of somebody who does not have prescribed ketamine.
Mm, yeah. And then you mentioned the possibility if somebody is untrained, they could potentially prescribe it to someone who doesn't actually need it. How would someone know whether they need it or not?
Well, right now the indications are we use it for depression, anxiety, and PTSD. So the way it works is the patients come to us, we screen them for each of these three diagnoses, and we rule out certain other diagnoses like active mania, hypomania, or psychosis. Um, so we do a full psychiatric evaluation and full medical evaluation, making sure they don't have some of the potential relative contraindications, like if people have uncontrolled hypertension or many other situations in which raising blood pressure might pose a risk to the patient.
And then what would, I guess, is there a level of severity of the depression, the anxiety, or the PTSD that you would say, yeah, come see if you need it?
The Again, we could get very political with DSM stuff here and overdiagnosing, but and the same applies. And I'm just not going to answer it in terms of ketamine, but the essence of the clinical diagnosis comes from not only having the person met the criteria, but also the duration of those criteria and the functional impairment. So somebody could have two or three or five or six symptoms of depression and not have any functional impairment, been going to work, etc. So and so yeah, so you do need to meet criteria. The problem is that many clinicians do not actually follow know the rule books of clinical diagnosis.
Right. Yeah. That I heard that loud and clear. Heard that loud and clear. Um, Anything that we haven't gotten to cover? Yeah, go ahead.
Yeah, but with regards to that, I think the indirect question there is: should ketamine be reserved for people with treatment-resistant depression? Could it be a first-line treatment for depression? Historically, up until not too long ago, it was only reserved for people with treatment-resistant depression or those who could afford going to a private office, get hooked up to an IV at eight or $900 an hour, and get ketamine. One of our earliest challenges were convincing people, or one of the things other doctors criticized about ketamine in the beginning was that the effects don't last, or you have to redose, or a variety of things like that. Or why would you give it the first line treatment of depression when we have these other medications? And the argument is totally the opposite. It's why would you give somebody a treatment that you have to take every day, wait weeks or months for it to help, and it doesn't help everybody, when you could give somebody a medication that is available as a generic agent, that is very, very, very safe, in that it produces almost immediate results on those who work with minimal side effects. Why would you deny people that treatment? So the answer is yes. Anybody that meets criteria for depression, anxiety, or trauma, or PTSD should be allowed to receive treatment for it.
Okay. That's helpful. That's helpful. In the couple minutes we have left, is there anything that I haven't asked that you want to cover?
Nothing comes to mind, but let me
Okay.
check. I think mental. There's an argument to be made for how can mental health be addressed in a different way in our generation? What could be different? Should people do psychedelics prophylactically? Should they be? I mean, so I think the paradigm shift should not necessarily be an external one, but more of a habits one. We should tell, we should teach our kids, which I do, that you know the mental health is part of the brain health, and the brain is an organ similar to your kidneys, your heart, your lungs. and you got to take care of them. You got to eat well, you got to sleep well, you got to avoid certain things, don't put certain things in your body. And then once you cover those basics, and you got to have healthy relationships, you got to know how to treat people and how to be mindful of those relationships and those connections, that takes you to a different level of meaning and connection and fulfillment. And if you cover those bases, you probably won't need much mental health treatment.
Yeah. I love it because, like you said, it all fits together. It's integrated, and we can't separate the mind from everything else. Because if we just do the simple things, like you mentioned, we can take care of ourselves for the most part.
That was one of my regrets initially in psychiatry, losing my medicine, my medical skills, until I came to the realization that I didn't have to, that it's totally connected. And then I went back and then I started reading and restudying medicine with a broader approach to it, a full body approach.
Yeah. Oh, man. Okay. Like you said, it takes you to the next level. That's good stuff. Leo, thank you so much. I appreciate this. This has been so fun and helpful just for me, and I know it's going to help a lot of people as well.
I hope so.